सर्दियों में गले खराब होना आम बात है. If you have kids, you know the winter clinic routine. Waiting rooms filled with anxious parents and coughing children. Most of the time, it's a routine viral cold. But those mild symptoms can mask a rapidly closing airway or a bacterial pathogen that leaves the throat to cause damage elsewhere in the body. We tend to think of the throat as a single uniform pipe. In reality, it is a complex intersection of highly specific tubes and valves. Where an infection lands dictates the level of danger. For doctors, a pediatric respiratory visit requires a precise evaluation. Identifying the specific symptoms of croup, epiglottitis, or strep determines if a child receives a prescription or immediate hospital care. The battleground consists of three anatomical zones: the larynx, the epiglottis, and the pharynx. Inflammations here give us laryngitis, epiglottitis, and pharyngitis. These passageways are narrow. Swelling in these specific zones changes how the body breathes and how doctors respond. To find the actual threat hidden within a sea of ordinary coughs and sniffles, doctors rely on a strict process of elimination. Consider the first patient profile, a toddler, somewhere between 6 months and 3 years old. They have an inspiratory stridor, a high-pitched wheezing sound when breathing in, and a distinct cough that sounds like a barking seal. This is croup, a viral attack, usually from the para-influenza virus, targets the vocal cords. The tissue inflames, significantly narrowing the airway. We see this narrowing clearly on imaging. This anterior-posterior neck X-ray reveals the classic steeple sign. You can trace how the airway tapers symmetrically like a church spire, proving the subglottic space is restricted. To open that space back up, modern intervention relies on corticosteroids and nebulized adrenaline to rapidly reduce the vocal cord swelling. That barking cough sounds terrifying in the middle of the night, but with these standard treatments, croup is highly manageable and rarely fatal today. Pivot to the second scenario. The child has that high-pitched stridor, but they are not coughing. Instead, they are sitting completely still, leaning forward, and drooling. This is epiglottitis. The culprit here is a bacteria called Haemophilus influenzae type B, or Hib. It attacks the specific flap of cartilage that covers the windpipe during swallowing. The mechanical danger is immediate. As the epiglottis swells, it turns into a physical plug. It can quickly fold over and seal the airway shut. This lateral neck X-ray provides the clinical proof. Normally, the epiglottis has a thin, leaf-like appearance. Here, you see the thumb sign, a swollen, rounded mass of inflamed tissue. The emergency protocol is strict. Agitating the patient can cause the airway to spasm. Doctors must immediately secure the airway through intubation and administer a powerful antibiotic like ceftriaxone. Misdiagnosing epiglottitis as croup is a fatal error. A child who is drooling and not coughing has a medical emergency that requires an immediate ambulance. The third scenario has no airway blockage at all. The patient presents with intense throat pain, swollen glands, a fever, and a bright red throat, often dotted with white or gray spots. The pathogen here is group A streptococcus. This bacteria is responsible for up to 30% of all childhood pharyngitis cases. Untreated strep bacteria can trigger an immune response that leads to rheumatic fever. This condition causes permanent, irreversible damage to the heart valves. To confirm the bacteria, doctors use a rapid antigen detection test. Within minutes, they know if group A strep is present, allowing them to precisely target the infection with antibiotics. Deploying those antibiotics actively prevents the bacteria from causing acquired heart disease later in life. Soothing the sore throat is merely a side effect. The introduction of penicillin transformed the management of these infections. This medical shift made the once common complication of rheumatic fever a rarity in higher-income countries. In the 1990s, the introduction of the Hib conjugate vaccine resulted in a rapid, sustained drop in epiglottitis among children, largely confining the disease to unimmunized populations. Before these modern interventions, children with severe respiratory distress frequently required hospitalization in oxygen tents just to survive the night. Today, rapid testing, effective vaccines, and targeted steroids have turned historical death sentences into conditions routinely managed in an outpatient clinic. The triage rules are straightforward. A barking cough requires steroids to ease vocal cord swelling.
Drooling while leaning forward means call an ambulance to secure the airway. A severe red throat with a fever demands a rapid swab to protect the heart. The physical margins within the airway are narrow, and the pathogens are specific. There is absolutely no room for guesswork. Bimari apni jagah se pehchani jati hai. The disease is known by its location. In the complex anatomy of the throat, precise information is your greatest defense.